So it's a case number 8, if they're going to show you, is a 68-year-old male who actually presented, sent to me from the vascular surgeon. Stable angina. He was pre-op for peripheral vascular surgery 2 months ago. They did a stress test, as you know, for every pre-op they do. But what he had was anterior ischemia with TID, with normal EF. He was on good medical therapy, and what we did was we did a cath, which essentially showed that he had two-vessel disease, which if you see here, RCA, the PDA, moderate about 50% or so, but more important was the CTO of the LAD. Calcified prox LAD. But the also question, is there a CTO in the mid also? See there?
Yeah.
You only see the filling of the LAD further down. And circ was okay.
Yeah, you have collaterals from the right.
Yeah, circ had a lesion, which we did a PCI of the circ at that time, and then we let him go for his peripheral vascular surgery. He was on 2 therapy and continued to have symptoms on therapy. So now this is now 2 to 3 months since his vascular surgery, and today here he is for the PCI of the CT of the LAD. So we have dual injection, as you see there. We have this case where you can go both antegrade, retrograde. We are ready to go with a guide on the right side if we decide we want to go retrograde. But first we'll try antegrade.
This is like a lot of RAO, huh? Don't you like?
Steep RAO cranial.
Yeah.
I think for the proximal lesion it's pretty good.
Look at this caudal. Small beak, you see that?
Yeah.
And then you think that could be, short total occlusion, but more important is way further down what is happening to this vessel. Yeah. So what are the catheters that you would want to go with, whether you go with the fine cross, teleport, so many of these other new turnpikes. There's so many turnpikes now. And then you have micro 14.
So it depends who you ask. Some people prefer turnpike. Some people say still okay to go with fine cross. I think it's more important which wire would you start with. If you start with XT or you start with something more robust, again, this is also a moving target.
Yeah.
Yeah, the support of the beak is a problem because when it's so short, it keeps prolapsing into the circ, and so probably a more supportive.
Yeah, I wouldn't use a fine cross
Exactly.
because it's not really enough support and it's not going to torque through very well. The Turnpike LP, Corsair Pro, et cetera. And it looks like you have antegrade flow there. You should be able to find a micro channel. So a Fielder XT would be a good wire to start with.
That's exactly what we do.
Okay. Samir?
Yeah, I think you're going to start with the Fielder XT and proceed with the further escalation, possibly using one of the Miracle wires, maybe a Gaia, but let's see. I still, in your history, I didn't get a clear idea as to how much do you think is the duration of the CTO?
Oh, duration of the CTO could be longer than what we think it is, because he was a stable CAD patient that presented to the vascular surgeon. So all this thing, the reason he got positive, he had a stress test because he was managed on medication only because he is a pre-op for vascular surgery.
Did you open the fine cross already or not?
We have opened the fine cross.
I knew it.
But we have a teleport ready. We have also the Corsair ready. Yeah. We have got 2 Corsair if you want for antegrade retro. But the wire of choice?
XT.
XT.
Fielder XT.
XT.
Yeah, absolutely.
We have consensus here on the panel.
Okay, and then if Fielder XT does not cross?
Confianza?
So a Pilot 200.
Pilot, yeah. Pilot 200 was a wire that we worked on for expert CTO. Good. So the progress? No, not progress. Also the,
I'm going to go straight with
Or confianza.
Why not to move directly to Confianza?
Too much.
I would not use the Pilot 200 because it's a recipe for dissection.
Escalation is to confianza. Or there
I
are
prefer
even
to go directly
operators
to
go
Confianza.
directly to confianza.
You don't have to jump right to
Chaffee's
a
with me.
Confianza Pro. You could go to something intermediate as There's fighter wires, there's Fielder XTAs. They are 1+ gram wires that'll give you a little more body to try to get through.
So I think what is a good, since the beak is very small, you see that?
Yeah.
Normally, I would say go with the fielder, which you could say go with the fielder so that you can get in. But like Pedro Moreno mentioned, what is going to happen here, you have a large left main, large circumflex, which is exactly like a big branch there. Fielder will prolapse into all these branches. So you would want a wire with something that is not hydrophilic, hydrophobic tip, and you will be able to get into the LAD. So likely, which was a miracle. The reason I'm talking so much, I think Samir Mehta should have guessed what has happened.
Yeah, the other option is always, I mean, you have the
Well,
Gaia
that's-
family
that's-
wires that they also.
I mean, I was always, right from the beginning, I had a question as to how much is the chronicity, because you may be able to pass it very easily too.
Yeah, and the mid segment is also occluded, so it's a very long segment that you're going to have to navigate. That's why going aggressively
I
with
think
it.
the mid is going to be the
Is
I think the escalation strategy here, you definitely try your fielder, whatever fielder you want, fielder XT. If you did not, Gaia would not be a choice. I think you would want to go with the Miracle, and then if that does not work, go to Confianza straight. And guess what?
Miracle
Within,
6?
Huh?
The Miracle
Yeah.
6 you will do?
Miracle 6. Miracle 3, Miracle 6, which one? I like Miracle 6, but this is not a case for Gaia. So that is what we did, and just in, I would say like in
This
2
is the
minutes we are able
Miracle?
to cross. This is Confianza.
Confianza,
So what
yeah.
what made the turn into the LAD was Confianza. Here, you see that? So fielder could not make a turn. What was it? The Gaia did not make a turn, but as well as the Miracle 6 did not make a turn. So it was the Confianza 9 that made the turn, and we are up to the apex. Then we had fine cross. We changed it to run through, and now we'll balloon and stent it.
AK, usually you usually take your workhorse wire right to the beak, right? And then you switch.
Yes,
Make
but
a turn.
Yes.
here was we were not able to, we had to engage the LAD. See, the beak is so small. So your usual workhorse wire, you're saying what? Use a run through BMW?
Yeah, to make that turn and then just put that. I usually use a Corsair and I will put it right to the beak. And then,
You did it with the fine cross or with the, which was the
No, I use fine cross.
fine cross? Okay.
Yeah, if you have something more supportive, you can get more purchase there and get through with a less aggressive
So
wire.
now
but
it's the same
both
thing.
work.
If you know the fine cross has crossed, then you can go with a 2530 balloon and then pre-dilate it.
So were you able to get the fine cross through the entire
Yes.
length? Yeah, so you're good.
Yeah. Okay, go.
Job is done.
Yeah, we were waiting for you guys to come live down.
We had to fix a nasty crater at the left main.
You think so? Let's take a picture and see what is happening rather than dilating, not knowing.
Probably you won't see anything.
Oh,
yeah.
no, there is disease there. Right?
Start with the distally. You are in the distal vessel.
Go up here.
You need a
212. I mean, maybe a new wire, but
Yeah.
let's see. It may go once we dilate it. Okay, down. I think this is chronic and calcified. $212, right? Go up.
So in this case, if you have a small balloon like
Down.
2.0, 2.25, you can go even
Yes,
further
yes,
distally.
yes.
And
I
go
think
from distal to proximal.
so. Other group of wires that we never discussed in this kind, if there's calcific lesion, is the progress family, which actually was tested in expert CTO trial. They go from 80 to 200. So they are a combination of fielder with Confianza. The tip is hydrophobic, hydrophilic, and the body is polymer coated. So in the calcific lesion, it could work. And other thing that really works in a heavily calcified vessel are the astato. Now astato, which used to be for peripheral, they have coronary wires also, which would be 20 gram. So
they are
the
very
highest
powerful.
gram, the highest gram of all this coronary CTO wire, which is the 200 progress, goes up to 14 grams. So you want more than that, you have to go to astato 20, and then you have astato 40.
But the stato are very, very powerful and very dangerous to perforate. And we actually we're using those to puncture the aorta for the transcaval.
Okay.
We use as a last resort, only as a last resort.
Yeah, that's what I was trying to say. Now, what's the name of that catheter that can give you deflection? I was thinking
Venture.
about
Oh, venture.
Yeah, that's
venture.
right. So that
Yeah,
one
venture.
was another option to use
Yes.
for.
Good. Venture or even the supercross. You know, supercross comes, it's over the wire. Venture has both over the wire and you have a monorail, but
pull back.
the supercross, which comes 90 and 120 angle, that is over the wire.
Yeah, so that was another option to tackle
Yes.
the entry.
Bring the schedule from there.
Okay. This is, I think, probably calcified. Okay, go up here. Now we have to go with the 3.0, right? That was 2.5. This is a 2.0 here. Okay, down.
Next page. 5:15. Okay, we are ahead of the time.
Go up.
Yeah, but we have plenty of good talks
Yeah.
this
has to be.
afternoon.
Now, not only that, tell
Done.
everybody there will be a 2 raffle.
Done.
The people who will stay till the evening, there will be a 2 raffles. One is the iPad Pro and
Go.
the Apple Watch. And we have the raffle there. So they will go home with the iPad Pro or Apple Watch.
Okay, give me down. 3 or 20.
Those who will
balloon.
stay till 6 o'clock.
High pressure, high pressure. Go, go, go.
I thought that they're going to go with a lot of knowledge about the talks.
That's separate.
That everybody gets. There is no raffle on that.
That's part of it. That's the whole purpose was for entire day.
Go.
Yeah.
So if you don't see flow now, I think what you'd like to do is get the fine cross distally and inject some dye to see a
I
good
think
distal
there will be
vessel.
flow.
Now you'll see the flow now.
I think you would, yeah, but
Yeah. You can give some,
because you had
Good
the
stuff.
retrogrades coming all
Yeah.
the way to the.
yeah. There is another additional lesion.
No, there is a lesion in
Yeah.
the LAD. Looks like
Yeah.
after that D2 or D.
But it's open. You can always
Go
put
up
a
here.
stent at that level.
And further AK.
Yeah,
Yeah.
that's the one. Okay, good. Down. Let's see. I don't want
Even
to go
further.
keep ballooning everywhere until we know.
That area. No, crack that one a little better.
Yeah, I know it is not staying
Yeah,
there
here.
because a short balloon.
Yeah.
It slips.
So for slipping balloon, yeah, I'll tell you now, let's bring it there and go slow. You'll see. Slow. Do 2 atmosphere.
2 atmospheres.
Good. 4,
4, 5,
6.
7.
It's gonna slip. It's gonna slip.
No.
8, 8, 8,
Eight.
9, 10. Quickly. Go
12.
fast. Go fast.
14. Slow. Sharma's technique. Avoid watermelon seeding. You have to just go slow.
Very good.
Go to the bathroom and come back.
Yeah,
Come back.
that's separate. Or have a coffee and come back. I'm sure Ran and us, listen guys, we have lived the era of the balloon only. What I was able to do in the earlier case with the balloon only was largely because of balloon experience, which is no longer there now. It's only stents.
We used to have the perfusion balloons,
Yep, perfusion balloons.
stack
Okay.
perfusion.
Yeah.
So we are going to start stenting, long stents, right? What stent you decided?
So you look good. You want to show us in an AP cranial the
Good.
So this
distal
is,
LAD?
this is
Hold on.
another vessel like the other one that you just opened. It's the
No, I think this will plump up
Yeah,
once we
plump
put
up.
stent
Yeah,
and
it
give
will
some
open up.
vasodilator.
Yeah.
It'll plump up.
And the same thing, let them put the stent in the middle.
Yeah.
After a few months, we'll bring back and take care of the distal vessel if necessary.
yeah stage.
Yeah,
The
for
John
next year's
Fox. The
symposium.
John Fox technique. I
2
like
and
it.
530. 2 and 38. We put a 2 and 538.
Okay, let's put the stent because we have got few minutes only. Make a good decision.
We are getting the stent. 2 and 538. Aye, aye, aye.
Above the
It was
bifurcation, huh? Above that distal diagonal.
Yeah, about that.
Proximal, yeah, yeah.
Let it play. See
Yeah,
here.
yeah.
This is the decision.
Oh, you have dissection there?
No,
Yeah,
we are
you
okay.
have dissection there.
You have to cover that.
You have
Cover
to
what?
cover that.
It's a balloon effect.
Put a 2 Why a 275? There?
No, 2.5.
Then we need a 2.5.
Yeah, 2.5.
Get us a 2.5.
You can put a 2.5 short and then put a bigger one proximally. So key is, I always say in a very long lesion, you need to put a 2 stents. And let's say stent length, the lesion is
2.5,
45. Use a
No,
20
2.5,
millimeter
32.
or 18 millimeter stent distally, small, and then proximally use your full 38 millimeter.
2.5,
We don't
32.
have 48 available here. In India, we have 48 millimeter stents.
Now,
And
that vessel,
You don't have 2.532?
the lumen of that distal LAD beyond the second diagonal is
Yeah.
pretty small.
But you needed that.
Yeah, I know you need to stent, but you know what happened when you oversize.
Yeah.
He has the papyrus now.
The papyrus is here. The last case of the beautiful day.
Yeah, you don't want to end with the papyrus. That's not a good way to end.
Now, the question is really how distal you need to go here again. I mean, I would
So
stick
now-
to the mid. I wouldn't go after the distal diagonal.
I think after the second, the distal diagonal, yes, because there is
Yeah.
some, the point is maybe 225. If you have
We
available
had
not
two,
to
two,
2.25.
2.25. Stent also look into it.
You could always IVUS, right?
I'm with Dr. Shiufu.
Yeah. 225. Look for a 225. This we
Why?
can put
We have a
proximally.
2.5. This is a
No, but-
2.5. This is
no, but-
low mag.
Yeah. Okay, low mag. Okay.
this is low
Hello. Yes.
All right. Let's make a big mag.
Now, if this is a male, it's not 225
Yeah,
by
yeah, that's
default.
right.
You know, there are no 225 in male.
Good.
You don't have in US 225?
No.
No, male are
No, we have it.
bigger.
No. We have 225 stent.
Yeah.
Yes.
Yes.
No,
You
but
know,
they-
in
not
Europe,
going, right?
we
Put
would
the
use a
proximal,
drug
put the
eluting
proximal.
balloon.
Yeah,
I
Yes,
think
well,
this
that's-
is for
Two
IVUS, but they don't
five
have it.
This
So,
That was a good case for
Later,
drug.
yeah,
put a
with drug
2.25
eluting balloon
distally.
until...
No, open it. It's not open. Okay, get us
J
a
follow-
2.520 high pressure. You had right? 2.5? No, you have that.
So
Give me that
one thing I
2.5.
like to do in these cases actually is to IVUS because
Yeah.
you would like to know what the potential is for that diameter and choose the stent appropriately.
balloon.
Plus, I kind of use that as a test method to see if my stent's going to get down there. If the IVUS doesn't go, then I know I got to do more predilatation. So, but it gives a lot of useful information because
think
these
a
are
guide
underfilled
extender
vessels.
would help here again,
They're going to
right?
take months to be able to plump up adequately. I don't want to also leave, you don't want to oversize it, but you don't want to undersize it either when it gets
But you
back to
can
its normal diameter.
post-dilate, It's not, we know that you can post-dilate. You can put a 225 also because of the balloon that normally is compliant, and then you can post-dilate when a non-compliant. It's not then the stent size, you can post-dilate.
Go 2.25.
Go.
Go 2.25.
I'm-
He's suggesting 2.25.
Okay, see that?
That's the other thing, the angulation, that
Yeah.
curve.
And calcium. You
See
see the
how
calcium
they-
there, yeah.
How the
We did atherectomy here or no?
dog bone
Please.
inflation.
They already have criticized enough.
No,
for
no
atherectomy.
criticize. These are the cases.
Yeah. You're doing a great job, Kini. You're a great
Yeah,
operator,
yeah.
amazing operator. Huh?
Okay, down.
I'm
Only
impressed.
thing is,
Amazing.
our atherectomy
So
streak
good.
was broken in this case.
Go up.
No atherectomy. It may still be needed if you cannot crack the lesion. May still need it.
Down. Okay,
No, do that also at that angle.
done.
Yeah, I'm impressed how comfortable she is with the femoral approach now. The guiding is not moving.
Nothing. It's not comfortable because all these guides are meant to be a femoral approach, the shape, everything, and they just sit there. And you saw with the radial, even that other case, both the two radials we did. Which was other radial we did?
No, you have a completely
don't
different
know.
level of comfort.
It looks like now you could just stent to that first diag, right?
The
Okay, you
radial,
have the 2.5?
the radial
No,
for
no, no. You want
complexity
that?
is
No, what do you want now?
Godzilla.
What do you want?
Stent.
Stent. Put the stent. Go. You have it.
Makes the case more expensive too,
Yeah. Okay. Let's not open the discussion, radial versus femoral. Maybe you should. Pedro.
Well, we changed to a 99% radial now for elective cases. You know, it's 99, between 96 and 99%. So, but you're right. It's the price, the average price per case is more expensive because we're using the Godzilla.
So essentially, we needed to
all the time.
pre-dilate more.
But,
Yeah.
you know, you tend to
Some
send people home the same day.
It's a beauty. I mean, for the patient. it's
You
a
really
beauty. Yeah.
Good.
have to take in the whole concept of
Good, right?
cost of case.
No questions asked.
Good. Go.
And then we use the ulnar.
Well, you know, Pedro, we sent a lot of patients home femorally.
Good.
You know,
Ulnar now, huh?
Down.
thousands.
Yeah.
Go up again.
It's pretty good. Yeah, especially when,
Same day.
even when the radial is occluded and you ultrasound and you see flow. I mean, it's occluded by physical exam, but you ultrasound, you see flow,
Hand
you can use the
dysfunction.
ulnar.
Good. Now what's the length? Okay. That's a 32 cent. I know. So we could go
Little
3-0.
test.
Okay. No, now we're going to take cine.
You were right. This is kind of under.
Nice.
Yeah.
Okay.
This is a classical angiogram of these very old CTOs.
38. 3-0, 3-5. What do you think, proximal?
They're not.
I think it's a 3-5.
What was that? This was a 2.5?
This is a 2-5. Proximal, we'll put a 3-5.
And don't you give a little bit of adenosine for the
Okay.
audience?
Okay. No, we'll give some nitro, verapamil, all the
How about for the artery?
Psychotherapy for the vessel.
Yeah.
Well, actually, you know, Pedro,
Yes.
knowing that we are exactly on the dot on the time 5:15,
Yes.
it's okay, put on the side and start your lectures, and Anu will come down because I know Manesh Patel needed to give the lecture first because he had to catch the flight, then Samir Mehta, and then we'll put, and then everybody will do.
Yeah.
I'm
So
third.